Hi, good morning, everyone. And thank you, Jenny, for the introduction. And thank you, Myeloma Crowd, for inviting me to speak with you here today. I'm just going to share my screen. So what I'd like to do is just give a little overview of CAR T cell therapy for myeloma. I'll start with a little immunology 101 and talk about T cells briefly, explain how CARs are made and how we give CAR T cell therapy, go through some of the side effects, and particularly cytokine release syndrome. And then I'll finish up with some of the latest data on two of the CAR products that are furthest along in multiple myeloma and hopefully available soon to all of our patients. And so just for a very brief review, we know that all the cells in the blood come from the called hematopoietic stem cell. This is what we actually collect and give back during a stem cell transplant. And on the left, you can see the myeloid lineage, which leads to red cells, platelets, and neutrophils. And on the right, the lymphoid lineage, which gives us rise to our lymphocytes, our immune cells, including natural killer cells, B cells that make antibodies. And what we're most interested in today are T cells. And these are really unique cells of the immune system that can recognize other cells in the body that have become infected with viruses or parasites or bacteria, can destroy those cells, but also can form what is called memory. And so they can become long-lived and therefore have the ability to respond to those foreign pathogens like viruses, et cetera, down the road. And so we also know that T cells can recognize and in some cases kill cancer cells. And these are actually two electron micrographs showing T cells attacking cancer cells. So our body has the ability to do this already. The problem is that over time, cancer cells learn to evade the T cells and they become ineffective. They become dysfunctional. They're no longer able to kill. And there are several approaches that are showing promise in being able to overcome this. In the solid tumors, more of the lung cancer, melanoma, kidney cancer, for instance, we have what are called the checkpoint inhibitors. These are antibodies you might have seen ads for like Opdivo or Keytruda, which can wake up exhausted T cells. But these don't seem to work as well in some of the blood and bone marrow cancers like leukemia and myeloma. And so in those cancers, what's really showing the most promise are what's called cellular therapies, where we take the T cells out of the body, re-engineer them to be able to recognize the cancer and activate those cells and then put them back in. And that's what I'll focus on. And then we'll probably hear later in this session about the bispecific antibodies or bispecific T cell engagers called BiTEs that are also showing a lot of exciting early activity in myeloma. And the cellular therapy approach that's really showing the most promise is called CAR T cell therapy. And CAR stands for chimeric antigen receptor. You may remember the chimera from Greek mythology with the head of a lion, the body of a goat, and the tail of a serpent. And so a CAR is a novel engineered molecule with the head of an antibody so that you can actually make that T cell be able to recognize any cell that you want by targeting a certain marker on the surface of that cancer cell. And then it has the body and tail of a T cell receptor to allow to signal to that T cell to be able to grow and divide and form memory long term. And so the way this works is you need a vector, some delivery way to get the CAR gene into the T cells. And most of these use what's called a lentiviral vector. It's actually derived in many cases from the HIV virus, but the guts are taken out so it can no longer cause any infection. It can just get into the T cell. And then the T cell starts to make all of these CARs, these chimeric antigen receptors that sit on the surface. In this case, an example is targeting CD19, which is on some B cell cancers. And now this T cell, which formerly might have recognized a random virus, can actually recognize the cancer cell, come in and kill it. And so you have cytotoxicity or killing. You have production of what are called cytokines, ways to communicate with other cells in the immune system to allow those T cells to track to the tumor. And then what's most important is long-term persistence. This really is a living drug. You get a one-time infusion of these cells, and they can last for months and in some patients even years to continue to try to survey for the cancer. And so this is sort of a brief overview of how it works. Patients undergo leukapheresis. This is the same procedure many of you may have had if you had a stem cells collected for stem cell transplant. But in this case, we're collecting T cells. It's just a single time on the pheresis machine. These T cells are then transduced with the CAR gene and then activated to try to expand and are grown up over usually a 2 to 3 week period to large numbers. They're then reinfused back into the patient, typically after a few days of what's called lymphodepleting chemotherapy, a few doses of chemo to temporarily suppress the normal number of white cells in the patient so that the CARs have more room to expand and those T cells can then get in and start to attack. And this actually was first tested and shown to have success in the B cell cancers, namely acute lymphoblastic leukemia, ALL, CLL, and several subtypes of non-Hodgkin's lymphoma. And there were several centers that all reported initial studies in the early 2010s showing remarkable success in sometimes highly refractory patients. And what's been amazing is some of these can be durable. Some of the earliest treated patients are now 10 years still in remission after a single infusion of CAR T cells. And this has led now to 3 FDA-approved CAR T products for these indications: Kymriah, Yescarta, and Tecartus. And at the bottom, I've provided a link to a video. It's about 3.5 minutes. I don't have time to show it here, but if you get access to these slides later, you can take a look. It's just sort of showing the story of the first pediatric patient treated at Children's Hospital Philadelphia, a young girl who had a refractory ALL, got CAR T cells, and had a dramatic response and remains in remission now 8 to 9 years later. So a really nice little video to see how this works. Now, unfortunately, there's no free lunch here, and associated with this incredible efficacy are risks and toxicities. And the 2 main ones to be aware of are called cytokine release syndrome, or CRS, and neurotoxicity. And so when these CAR cells get activated, they see the tumor cells, they start to grow, and they release factors in the bloodstream called cytokines. And these cytokines can mimic basically a significant infection. This usually occurs within the first week after the CAR infusion, sometimes even within the first day or 2. And it often lasts for a few days, though in some cases, if it's severe, can last longer. And in most patients, it essentially feels like a really bad flu. You get high fevers, chills, headache, muscle aches, fatigue, and loss of appetite. Patients are typically admitted to the hospital, and treatment is supportive if it's just these type of flu-like symptoms: Tylenol, fluids, rest, and monitoring. But unfortunately, in some cases, the immune response can become overactivated, and this cytokine release can be more severe. Patients can develop low blood pressure, difficulty breathing, and rarely even damage to organs like kidney, liver, or heart. And low blood counts can occur as well. And so this may require ICU-level care and become life-threatening in a small subset of patients. The other big toxicity is called neurologic toxicity. Again, most cases, this can be mild, either headache or mild confusion in the setting of high fevers. It often occurs either during the cytokine release syndrome or can occur sometimes a couple days after. And again, in rare cases, this has become severe, leading to severe lethargy or seizures, rarely cerebral edema, which is swelling in the brain, or coma. And so initially, these were treated with steroids or other immune suppressing medicines to try to tamp down the CAR T cells. And steroids are still used largely for neurologic toxicity. But we actually have a more targeted sort of antidote for severe CRS called tocilizumab, or TOCI. And this was a drug that actually was approved for rheumatoid arthritis and some other autoimmune diseases, and was shown to be effective in severe cytokine release syndrome. It blocks a cytokine called IL-6, which is typically very elevated in severe CRS and associated with fevers. And after giving this, you can see rapid improvement. And most importantly, it does not appear to harm the CAR T cells at all or impact their efficacy. And this is just an example on the right from an older paper where patients started to have fevers. They actually had to go to the ICU and required 2 different pressors to maintain blood pressure and had some confusion. They got the tocilizumab on day 6. Fevers were gone within 24 hours. They got off the pressors within a couple days. They had some lingering neurologic symptoms that all were resolved by day 12. And by 2 weeks, essentially, everything had resolved completely. And there actually are ongoing studies now of trying to give early or even preventive tocilizumab in some studies with in B-cell malignancies, and some of these are going to get underway in myeloma as well. And we can maybe talk more about the pros and cons of early versus later TOCI during the discussion. Now, of course, we're interested in multiple myeloma. And so there were 4 studies that all started around the same time in 2015, 2016 that really showed proof of concept that this could work in myeloma. All of these targeted a different target on the surface of myeloma cells called BCMA, which is highly expressed on myeloma cells. There were 2 were single institution studies at the National Cancer Institute, or our study at Penn. The Bluebird study was a multi-center US study with a CAR product called BB2121, and Legend used a CAR product and treated at several centers in China. There were relatively small studies, 25 to 57 patients. There were different CAR constructs. The US studies had more heavily pretreated patients, 7 to 8 prior treatment lines. The Chinese patients were a little less heavily treated. But if you look at the far right, the take-home message is sort of once these studies got to optimal doses, very high response rates anywhere from 2/3 to up to 90% of patients responding, many of these with very good partial response or even complete remissions. And two of these products, the Bluebird product BB2121, which is now called idacaptogene viclucil, and I have no idea who comes up with these names, or Idacel, and the Legend product, which is now being partnered with Janssen and is called Cilta-cel. Both of these have now moved on to what are called registration studies and completed those studies, meaning that they have data that's going to have supported a submission to the FDA for approval. And the Idacel data has been presented already and submitted, and we're awaiting a decision in the next couple of months. The Cilta-cel data hopefully presented later this year. So I'm going to go through a little bit of the data that supports those registration attempts for you. And so the Idacel data is based on this study called the KARMA trial. This was a phase 2 trial. It was presented at our ASCO meeting in June of last year by Dr. Munchie. This was very heavily pretreated patients. So 128 patients with myeloma had had median of 6 different treatments, and the disease had come back. 84% were what we call triple refractory, meaning the disease had become resistant to a proteasome inhibitor like Velcade or carfilzomib, an IMiD like Revlimid or Pomalyst, and daratumumab or some other CD38 antibody. So these were tough patients to treat. And you can see overall, 73% of patients responded to the CAR. So about 3 out of 4 got a response, about 33% a complete remission. And if you look on the right at the highest dose level, the 450 million dose, which is what's going forward to the FDA, about 82% of patients responded, almost 40% complete remission, and 28% complete remission and what's called MRD negative, negative for any measurable residual disease, even at a very sensitive level of looking for less than 1 in 100,000 cells in the bone marrow. The side effects were what we typically expect from myeloma, cytokine release syndrome seen in 84% of patients overall. But fortunately, only 5% or 7 patients had what's called severe CRS, grade 3 or higher, which required perhaps ICU level care. 18% of patients had some neurotoxicity, headache, or confusion. Again, 3% or 4 patients had more severe neurologic side effects. Half the patients got that tocilizumab. And in terms of durability of response, on the left, I'll address your attention to these curves. This is called a Kaplan-Meier curve. It basically shows the percentage of patients at each time point that were still in remission, where their myeloma had not come back. If you focus on the highest dose level, the 450, that's this green curve here. At 6 months, about 75% of patients still remained in remission. At 12 months, about half the patients still had not seen myeloma coming back. About half of them had come back. And the follow-up was still short. We are waiting for longer follow-up. There are some patients getting out to 2 years now, still in remission after this single infusion of CAR T cells. The other study that was presented at ASH this year was called CARTITUDE-1. This is looking at the other BCMA CAR product that's sort of furthest along, called Cilta-cel. 97 patients, again, very heavily treated, 6 prior lines, 88% triple refractory. And in this study, 97% had a response, including remarkably 67%, almost 2 out of 3, who developed a stringent complete remission with the infusion of the CAR T cells, including a large proportion of patients who became MRD negative, meaning there's no measurable or residual disease in their bone marrow. In terms of the durability of this response, perhaps a little bit better in this trial, with 76.6% still in remission without progression at 12 months. But the follow-up is shorter in this study, and we're waiting to sort of get longer follow-up to see how durable these remissions are going to be. At least 1 patient now out 2 years without any relapse. Toxicities, again, were cytokine release syndrome and neurotox. 95% had CRS in this trial. The median onset was a bit later, day 7, compared to day 1 or 2 with the other study, and we can talk about that more in the discussion about some of the differences between these 2 products. Again, most of these grade 1 or grade 2, but a small subset of patients with more aggressive or severe CRS. And then in this study, 20% developed neurotoxicity, a little bit higher rates of grade 3 or higher, the more severe neurotoxicity, 10% of patients, including a few who developed a later neurotoxicity that developed even 30 or 60 or 90 days after CARs, a little bit unusual. And I think we need to get a little more follow-up in this study as well as other studies with this particular CAR construct to see how frequent that's truly going to be and if that's something that's going to differentiate this product And so I think I'll stop there. Really, the take-home points are the BCMA CAR T cells can induce really deep responses in relapsed refractory patients. These registration studies are completed now for these two products going to the FDA, and hopefully one or more may be on the market by later this year. There are phase 3 trials comparing it to standard regimens, for instance, Dara, Pom-Dex, or some other things to see if these are really better than what we have for standard of care. And there also are now studies doing less heavily treated patients, not waiting until all options have been exhausted. I think the durability of response for these heavily treated patients is good, especially that you really get a break without treatment for a fairly long period of time, but I think we need to do better. And I think the CRS and neurotoxicity, we're getting better at managing this and keeping it at a low grade, but obviously we could do better as well. And then we'll hear hopefully later today about some other next generation CAR products, some off the shelf products that I think are going to be interesting, where you don't have to wait for manufacturing, and even CARs that use natural killer cells. And so with that, I think I'll stop and thank you very much for your attention.